So this be a good time to review. I think we did, when we talked about her last time, at least I was questioning her bipolar diagnosis, and I guess I just kind of maybe assumed it since she came with the diagnosis and the medical records. I just assumed that it was a correct diagnosis. She did not respond well to Caplyta, and I appreciate the comments on Caplyta. We ended up changing her to Vraylar, and she has done significantly better, but she's not sleeping. So the message I got from her today was that Vraylar is making her too sleepy to take it in the morning, but if she takes it at night, she's not sleeping well. And she does take Ambien 5 milligrams. So the change from the Caplyta to the Vraylar did significantly help her symptoms. But now she's not sleeping.
So I don't pretend to have any knowledge of these GeneSight studies, but I'm really curious, and I want to ask Lauren if she would talk about, because you just mentioned Vraylar, and I think if I'm reading the paper that we got correctly, there was a significant gene drug.
I think that's a different case, Colleen.
That's for a different case. It's all right. It's all right, Dr. Lillard. It's for the next case we'll talk about. This is just from a follow-up case.
Well, I was really excited about this GeneSight study, but okay. So my apologies.
Tracy, did she give you any detail on what sleep problems she was having from that? I mean, was it onset problems? Was it nightmares? Did she describe the sleep?
Oh, I'm sorry. My internet is just glitching. It's going in and out. I'm hearing a few words. So if I talk over anyone, I apologize.
I think mine is too. I'm sorry. Mine is misbehaving as well. Did she just onset? Was the onset like excessive, or what did she report?
All I got was that phone encounter. But I do remember last time when she came in, we talked about the Vraylar, and she was taking it at night, and she said I'm not sleeping well, and at that time she said it took her a long time to initiate sleep. So I told her to take it in the morning, and that's been a couple of weeks ago. And so the phone encounter I just received this morning was that that she's not sleeping well. It makes her too sleepy in the morning, but if she takes it at night, she's not sleeping as well. So
I try to get a little bit more information about the sleep onset. Like, is she just not sleepy? Is she like having racing thoughts? Is there worry happening? I mean, I think this was the one that had some concern about kind of problems with sort of anxiety as well, and a question even of ADHD, correct? I mean, so I mean, I think even just the change could be a little while to adjust to. So kind of buying just a little bit more time to kind of reassess that sedation effect during the day. I mean, is she going to sleep when she's really tired, or maybe doing a little bit more in-depth sleep? I mean, the other things I can sort of think about, to kind of bridge just the adjustment, since the medicine is helping, sometimes some melatonin can kind of just help like re-enter into that new sleep pattern with the change in her mood. I know she had a question of ADHD possibly that hadn't really been explored, but even something like clonidine at night, or putting that guanfacine back kind of more in the evening, could provide kind of an anti-anxiolytic, adrenergic kind of effect. It may be, especially with long-term Ambien use, that could also have lost its effect. It does have a tolerance sort of profile to it. Sometimes stopping that for a while, even though sleep may be disrupted, restarting it could make it more effective. I think there's several things that you can do. I also think it's important that sometimes when people have marked improvement in their mood, some of that fatigue and tiredness gets better with improvement in the mood. Sometimes people are just returning to normal sleep, and it's all part of the the normal process if they were sleeping too much or too little. And so, you know, I think unless it's really disruptive, just kind of some psychoeducation and buying some time and working back on that sleep hygiene and sort of making sure, you know, that medicine settles in. I think she'll probably get there eventually, but you know, I'm glad it's really helped her in other ways, but I suspect the sleep may be kind of tied in with that mood stability and just getting a new pattern too. I don't know if other people have some thoughts, but I find it hard to really chase sleep when you're mood stabilizing. I kind of want people to kind of buy into the stability in their mood and go back to kind of getting their sleep structure right before I start putting on new sleep medicine, because they can kind of disrupt the sleep or the effects of the other medicine too. And it may be hard to tease that out a little bit.
And she also has 2 young children. So that could be possibly some of it also, but I will talk with her a little more in depth. And
I would say definitely part of it. I'd just go right for yes with that.
Yes.
Excellent. Thank you so much. Does anybody else have any further comments or questions before we move on to the next case? All right, no worries. Thank you so much. All right, I'll pull up that next case at 724, Tracy, and that is the one with the gene testing. It's okay, and I have that up and ready too. If you guys need to pull it up, just let me know.
Yes, so I'm going to redeem myself on this one. The gene site results have been emailed, I think. Mostly the interesting thing about this case was the gene site results. We had discussed gene sites 3 meetings ago, and then I ran across this interesting case, so I thought I would just present it to find out what do you do when you have a gene site that is not really, doesn't look very good.
Elizabeth, can we go right to the gene site report and show that? Because I don't know if everyone's ever seen one before. So just for a little orientation again, actually, can you go to the part where it actually lists the, there's actually a section that has the actual enzyme and whether someone's a poor metabolizer, intermediate metabolizer. It's right after these columns. So these columns are completely generated by how people metabolize medicine based on their liver metabolic profile. And so the guidance provided and what chart they go to has nothing to do with their diagnosis, has nothing to do with what medication will be successful. It has absolutely how to do with how they will metabolize it and what their risks of side effects are. And so it's guidance for you in dosing. So the first few pages are, okay, right there. So there's it does 2 things. One, there are some genotypes associated with serotonin, promoter regions and risks for just not tolerating so there's genetic risks or genotypes that might impact how alpha adrenergic or serotonin receptors are there. This was her profile. This was generally fairly normal part. This was not this patient's problem. She did not have a specific gene abnormality. She had a lot of abnormalities with how she processed. So the next section, if you'll go to where it starts saying the CYP enzymes. So the liver contains all these different enzymes, and there's okay, so this is the go down a little bit. This is the pharmacodynamic piece. So this is where you're really, I'm sorry, no, these are still genotypes. Oh, you're right, keep going. I'm sorry. All right, so this is where you see the pharmacokinetic stuff, where you really are seeing the extent of this patient's problem. So extensive is normal, and that means that your body handles this medicine as expected, and you should dose it as expected. When you see that people are poor metabolizers or intermediate metabolizers, intermediate's kind of in the middle, that means they don't process the medicine the right way. So if you give someone 10 milligram dose, their body is not going, it's going to look a lot higher because their body is not going to get rid of it the same way. So the CYP2D6, the CYP3A4, the CYP down at the bottom, 2C19, you see that this patient was a poor metabolizer at 2D6, 2C19, So, I mean, this means she is not metabolizing a large majority of psychotropic medicines appropriately. Okay. And so any drug that goes through any of those SIPs is going to end up in the yellow or red column that you can't see on the color coding, but is going to end up in the middle or on the right in the columns above. It's completely driven by this. So, and this document is just presented the same way multiple different times. So the first part has the column by drugs. You metabolize it normally on the left. You know, you're an intermediate, you may have some intermediate challenges, metabolism on the right. And then the red is you have extensive problems metabolizing this medicine. And then the middle section is the actual enzymes. And if you go to the bottom, at the bottom part is the third way, where by, if you want to scroll down, Elizabeth, even further, the third part of the report is just by drug. So instead of being column by dosing, you just see it by drug. And so just this is the same version. And if you have a dark circle or a half circle, you might have challenges metabolizing. It's the clear circles that would be normal. So you can use this report many different ways. Again, you know, people think, oh, it's going to tell me what drug will make me better. It still doesn't do that. It's important that you have a good diagnosis and a good plan. But as a clinician, I believe this was the lady that had pretty substantial panic disorder, and really bad anxiety. Is that right, Tracy? What you would do is look at what medicine, you know, normally what medicines would you pick for that? So let's say I would typically pick an SSRI, maybe I'd pick a benzo. You could go to those medicines and see what the rules are about that medicine. Generally speaking, like if you're going to pick something, like right here, you know, generally if you're going to pick something, and this is what the first range sort of put through is, because she's such a poor metabolizer, you're almost going to have to choose whatever you pick at a very, very low dose. You do not want to start with a normal starting dose. That doesn't mean you can't give the medication, but if you would start it at the normal dose, that patient's going to get side effects and have intolerability. So if you go all the way back to the columns at the top, this is really a guide for the clinician on how to dose it at the end of the day. So if we go all the way up to like the antidepressant, anti-anxiety medicines, we can keep going. Okay, hold right there. So this is a list of several SSRIs, SNRIs that would traditionally be used for generalized anxiety or panic disorder. And you can see that none are in the uses directed column. So because again, remember, she's not metabolizing anything normally in her pathways. But if you look at those codes, like the 1 and 6, they say, you know, be mindful of the dose, higher risk of side effects. So if you're going to start something like, if you can pick something in the middle column with less interaction, you probably will have less side effects. You still need to dose lower. So if you can find something in that middle column that's more tolerable, you would start there, but you'd want to make sure you still reduce the dose and you still go very, very slow. And so you would start there. If you could still pick something in this far column, but you need to be even more cautious, start even lower. And so, you know, you have to know what dose the drug comes in and if the pill is breakable, or what I would even say with a lot of these is see if you can find one that's liquid and start even lower with the liquid. And so like things like Prozac, Lexapro, Zoloft, they do come in liquids where you can start at a couple of milligrams and go really, really slow. Or see if the pill is scorable and you could break it into a quarter pretty easily so you have some dose inconsistencies. But I would start at least a quarter, about a half or a quarter of the starting dose if you can when you see these types of profiles. Does that help a little bit?
I think we lost Tracy, but she, you know, can refer to this and I'm taking notes of her, but I find this really interesting. We did have someone in the chat say, so lower doses for poorly metabolized meds.
Correct. So that just means that if I give you, it just hangs around a lot longer. Your body doesn't clear it as fast. So a higher dose is going to hang around longer and cause more side effects and not clear out as much, and you don't need as much. So, you know, being very, it's still very patient specific, but let's say a typical dose for depression is Lexapro 10. If you're a poor metabolizer like she is, maybe you only need 2 milligrams or 5 milligrams. Your body may process that lower dose and hang around with it because it's not clearing it out as fast. So this is, you know, this is really helpful when you've had a patient fail medicines due to side effects at normal doses. I think sometimes people think that this is magic, but this does not tell you, like, you know, you go down to the columns and you'll find some things in the green that use as directed, but there's no reason to give the patient that medicine if they don't have that problem. So you can't just pick something in the green column because they metabolize it well. It's still not going to necessarily treat the problem. And I think that's been probably the hardest thing, I think, for clients to kind of understand is, oh, it's going to tell me what medicine I need. Well, yeah, kind of, but it tells you more how to dose it and tolerate it. It doesn't really change the importance of the diagnostic process, because when people don't respond to medicines, you know, what should be our first approach? One, did we get the diagnosis wrong? And is it the wrong medicine? We need to go back to the drawing board. Maybe we're really sure about the diagnosis, but they're having unexpected results. And when you're really sure about the diagnosis, you're persistently seeing people not respond. And it can even be to high doses. So this was an example of poor metabolizers, but you'll see some that are ultra rapid metabolizers where they burn through it really fast. Those people actually need higher doses. So sometimes the pattern is that you have to dose it higher than expected if they would be an ultra rapid metabolizer. So, and then sometimes this one didn't have it so much, but sometimes there's actually gene or transporter issues that make them more sensitive to an alpha agonist or serotonin, and that can impact it too. So this is really about how the drug is processed in the body and explaining the side effects. And that can be really, really important sometimes, because, you know, that's often why people don't do that. So the question is, how difficult is it for providers to get these reports? The testing is actually quite easy. It's a cheek swab. You twist it 10 times on each side, you put it in an envelope and you send it back. You do have to meet some medical criteria for most insurance plans to have it covered. And this is why you can't just absent-mindedly sort of just send one. You do usually have to demonstrate at least 2 failures of medications. Not all insurances will cover it at all. There's some health plans like PEIA was not covering it all, never, ever. But the test range is quite, depending on what company you use. The GeneSight company was, I think, charging around $300 out of pocket if you didn't have insurance. The cost to the insurance company is almost $1,800. So if they're billing insurance, it's a pretty pricey thing. So you have to still sort of support. And this has most evidence for sort of people that have needed an antipsychotic or antidepressant or SSRI that have failed because of side effects. So you usually have to report the diagnosis and what the failures were at expected doses, and demonstrate that to get insurance coverage. But you could just get it. I mean, the provider has to enroll and enter into the database, usually to get the report, or they'll just send it directly to but I mean, they have marketing people that come out. There's also another one that's out there. I can't remember off the top of my head what other company is doing it, but I mean, it's fairly easy to get. It's just pricey. And so you don't want to lose the report, and there's no reason on this planet to lose it, because this is permanent information. I also will say, and this is really helpful, is those enzymes are the same ones that impact other drugs. So even though that they're only doing it for psych reasons, if you're a poor 2D6 metabolizer, you need to make sure your PCP knows too, because it affects a lot of other drugs that aren't on that report and may explain a lot of things if you take an antibiotic or you need chemotherapy. So, you know, if you document that you're a really poor metabolizer, you kind of want that in your medical record for all other drugs too, because this is just the psychiatric pretty picture they paint, but these are the same enzymes that affect all medicine. So you don't want people to lose this information, even for physical health reasons too.
Wow, that's really interesting. And I wish we could all take it. I want to get it done. See where I'm at, but that's really interesting. How about a question when somebody's coming off? So if they're this type of metabolizer, do you have to wean them off differently as well? Like even slower than you would a normal person with the half-lives and everything?
Yeah,
or-
so if you're a poor metabolizer, it's going to take a lot longer to clear the drug from your body. So you might have protracted withdrawal. If you're an ultra rapid metabolizer, you're going to clear it faster. So yeah, it may impact how you taper off something or how long people may experience some withdrawal effects too.
Excellent. Thank you so much, Dr. Swagger. Does anybody else have any questions or comments? And we did lose Tracy, but really appreciate that. And I have a couple more cases of hers, but I'll just keep them for now. We'll go to the didactic. If she comes back and we have time, we'll do it, or we'll move it to the next session. All right, Kelly, are you ready to present your didactic?
I think it's Claire today, right?
Oh, Claire, I'm so sorry. Claire.
I am.
Excellent. I'll give you the capability to go ahead and share your slides.
Okay. Okay. Can y'all see that? Perfect. So I am going to do my best to talk about autism in a very short amount of time. I've given similar talks about autism all the time, but usually a lot longer than 15 minutes. So if I fly through it and you have other questions later, feel free to reach out or, stop me or whatever. So the quick and dirty lowdown on autism. So autism is, hold on, I'm gonna get this out of my way. Okay. And defined in the DSM-5 TR by two areas. So we're looking for deficits in social communication as well as certain behavior patterns. So with social communication, what you'll see is these persistent deficits across contexts. So it can't just be in one setting. And it's not accounted for by general developmental delays that a person might have. And you have to have difficulties in all three of the following areas. So social emotional reciprocity, which is kind of the back and forth, not just conversation, but just in general, kind of the feel of having interactions with other people. Developing and maintaining relationships. So difficulty kind of developing friendships, maintaining friendships, or work relationships or whatever type of relationship it might be. And then nonverbal communicative behaviors that we use for social interaction. So not just eye contact, but gestures and facial expressions and things like that. So that's one piece. And then the other piece that we're looking for is certain behavior patterns. So restricted repetitive patterns of behavior, interests, or activities, and you have to have at least two. So we're looking at things like stereotyped or repetitive speech, motor movements, or use of objects. So saying things in a certain way, kind of scripting is what it's commonly called. Repetitive motor movements, a lot of people think about rocking or hand flapping, but those aren't the only ones you can see, or using an object in a repetitive way. There's also excessive adherence to routines, ritualized patterns of verbal or nonverbal behavior, or excessive resistance to change. So needing things to be done a certain way. This can look a little OCD-like at times, of not being able to, walk through the threshold of a door without having, a meltdown of some kind, especially for kids, but adults as well. Or, I get totally discombobulated because I wasn't expecting that mom wasn't going to take me for ice cream after school like she always does, and we have to go to the grocery store first, even though that wasn't on my list of things to do today. Another thing that we're looking at is highly restricted or fixated interests that are abnormal in intensity or focus. So everybody has their area of interest, things that they like, but this is a very strong fixated interest. So commonly people will think about trains, but there's other things too. Cats is a common one that I see, especially in females. I'm not sure what the data is on that. That's just an anecdotal thing. But you've got people that are, they might be a history buff, or they really like to take their cars and line them up. And so that kind of goes across the different behavior patterns that we're looking at, but just kind of this really intense focus and interest. And the last piece is hyper or hypo reactivity to sensory input, or unusual interest in sensory aspects of environment. So certain things that they are over or under reacting to from a sensory perspective, and that's across all 5 senses. So a little bit more in depth on the social communication component. So these deficits are going to include things like abnormal social approach. So walking up and standing right next to someone, difficulties with understanding personal space and boundaries. It can be, you know, walking up and then just talking as if you're mid conversation already and you haven't even introduced yourself. It could be, you know, keeping back and kind of observing as opposed to going up and trying to introduce yourself, and not necessarily for an anxiety reason, but maybe because you don't know how to interact socially. The deficits in nonverbal communication, so eye contact for sure. So you can have really strong eye contact that's really poorly modulated in that way, where you can have really fleeting or quick eye contact. You can have eye contact that kind of feels like they're staring through you rather than at you. So they're looking at you, but they're not really looking at you. Gestures, you could have minimal use of gestures, you could have really odd use of gestures, and then facial expressions. You could have no facial expressions, you could have facial expressions, but you're not directing them to other people. You could have very overt, exaggerated facial expressions, almost like you learned that this is the expression you're supposed to have. Reduced sharing of information, emotions, or affect. So not necessarily understanding that these are things that you can and maybe should share. Sometimes oversharing because you're not understanding maybe the social context and kind of reading those social cues and social norms. Trouble initiating or responding to social interactions. So if someone comes up to talk with you or ask you a question and you are very blunt with them, or you don't respond to them, or you respond to something that's not even related to what they were saying. Or, you know, going up to people and trying to initiate an interaction with them. So like I said earlier, talking to them mid-conversation, or walking up and, you know, you're supposed to say, you know, hi, I'm Claire. I like trains. Do you like trains? You just like walk right into like maybe an area of interest that you have or something that you're currently preoccupied by. And then trouble with that back and forth conversation. So this is a big one where maybe I don't understand that when somebody else talks to me that I should then ask them a question about what they're talking about or make a comment about what they're talking about to keep that back and forth going. That can be really hard too. Even things like what we call social bids. So something like, oh yeah, I went for ice cream yesterday and it was so good. And then you just leave it there and see, are they going to ask, where did you go? What kind of ice cream do you like? Or, oh, you like chocolate cake? I like a different kind of cake. Do they respond to you? Do they not respond to you? Do they say, cake is good, but I actually like brownies? Or do they follow up and say, no, what kind of cake do you like? Trouble adjusting behavior to different contexts. So we see this a lot in clinic, especially, but you can see it across settings and contexts of understanding how am I supposed to behave in this moment, especially when there's other things going on that may be overwhelming. So not necessarily understanding that in some locations or places, I should be, you know, a little bit more quieter, sitting where I'm supposed to sit versus loud and rambunctious, and those kinds of things. And then lack of interest in others, not necessarily because I don't care or don't want to interact, but maybe because it's hard. Or maybe because it feels like I've had these repeated attempts and people just don't understand me and I don't know what to do. But generally speaking, we do see a lot of more limited interest in others initially, though I will argue anecdotally that I can usually drill down and see that my patients want those social connections. It's just really challenging for them. So when I think about the social communication deficits in autism, it's less about, you see the social communication deficits across different disorders and presentations. But for autism, for me, what I see is that it is really at the core that they don't understand. They don't have that foundation. You know, a kiddo with ADHD is going to come in and have trouble with eye contact and social reciprocity and conversation and staying on topic. But if I can get them to focus and attend, I can probably get some really good interaction, which means that they kind of have learned over time and picked up on those social cues over time of what's appropriate, what's not appropriate. They're just having trouble regulating. In autism, because part of it is missing out on social cues, there's things that we inherently learn as we're growing through observation that they're not picking up on. So then they're at an added deficit there. So it's, you know, you kind of have to teach when I want to go introduce myself, this is how I do it. This is why we have to make eye contact. This is why we have to do these things. So then the other piece with the restricted repetitive patterns of behavior, interests, or activities, these are things, again, stereotype repetitive body movements, object use, speech. So saying the same word over and over, repeating things that other people have said, using phrases or words or full sentences or paragraphs from movies or books or TV shows. Very insistent on sameness. So I need things to, this has a place and it should always be in this place, or we need to follow the same route to school. And if we drive a different way out of the drive, if we turn the different way out of the driveway when we are leaving in the morning, then, well, we were supposed to go to school and we only go to school this way. Or if I'm told this is the plan for today, and then spontaneously we have to stop and get gas or grab milk from the grocery store, well, that wasn't on the plan for today. So that's going to cause me a lot of difficulty. Highly restricted and fixated interests. We kind of talked about that already. The hyper and hyporeactivity to sensory input. So that's going to be things like, so starting with vision, these are things like maybe bright lights are too bright. Or maybe I like looking at light reflecting off of things, or I like to look at things out of the corner of my eye because that's a sensory component. I hate that feeling, but a lot of kids really like it. Or I hold things really close so that way I can see the tiny little piece of it. I'm visually inspecting it. Auditory is usually loud noises, but not always. Sometimes it's certain noises or things that we don't tend to pick up on. You get used to the wind chimes outside of your house, or the fridge turning on, or the air kicking on. They don't bother you. You kind of tune them out, but these are things that maybe I'm more sensitive to, or I'm holding a toy up to my ear so I can hear it better. Touch, so that's going to be clothing textures that you feel with your hands. Pressure, deep pressure on your body. A lot of people like that. A lot of people don't like that. So tight hugs, heavy blankets, those kinds of things. Pain tolerance is often off. So usually a really high pain tolerance, but not always, sometimes very low. And then olfactory, which I don't see as much, is not as common, at least in the patients that I work with. But, holding things up to their nose, sniffing things, sniffing something before they eat it every time. And then, of course, the typical like picky eating, selective eating, whether that's because of textures or the way something looks, or mouthing and eating objects. So the last piece here is the extreme distress at small changes. So I've had a kid before, very affected and low functioning, and I had a student that was with me move the table over just slightly so that way he wouldn't hit it when he was pacing. And he moved it over maybe 2 inches, and it led to a total meltdown. So it's not always that small in terms of trouble with a small change, but if you're moving, rearranging furniture, putting up holiday decorations, those kinds of things can also be really overwhelming. Briefly, theory of mind. So this is a big piece that we look at when it comes to autism. So theory of mind is the idea of being able to understand what other people are thinking, feeling. It helps us predict and interpret other people's behaviors, because we can kind of see, okay, well, if they're doing this, then they're probably thinking this or going to do this. And we have to be very intentional with theory of mind. Theory of mind is something that's very intentional. So we know people are going to act according to the things that they want. And we have to be able to pay attention to other people and imitate that or pick up on those things. And that's really hard in people with autism. Kind of that perspective taking piece is really challenging. And commonly we assess this through like false belief tasks. So one activity is, here's a box, it's got pictures of blocks in the front. What do you think's in the box? Blocks. Open it up. Yeah, you're right. Here's another one. The box looks exactly the same. What do you think's in it? Blocks. You open it up, it's actually pencils. Okay, so if mom came in the room, what would she think is in the box? Would she think that it's blocks, or would she think that it's pencils? And if you have poor theory of mind, you would say, oh, mom's going to think it's pencils. But if your theory of mind is relatively well developed, you're going to say, oh, she's going to think it's blocks. Like, oh, that's a funny trick kind of thing. So autism, just a couple brief stats. Currently, the CDC is telling us that based on their most recent research update, 1 in 36 children in the United States has autism. And we know that it commonly affects all ethnic and socioeconomic groups. There's no differential there in terms of occurrence. 31% of people with autism also have a co-occurring intellectual disability. 40% are nonverbal, preverbal, or non-speaking, and 28% of 8-year-olds that were the research was done on have self-injurious behaviors. Causes, we know it's not vaccines, even though I feel like I'm commonly or frequently telling people promise you it's not your vaccines. But we do know genetics is involved in a large number of the cases. For people that are having families that are having a second child, and their first child or another child, an older child, has autism, there's a 2 to 18% chance of recurrence, and those numbers vary just based on, you know, the literature and how the research was done. With twins, there's a greater risk of identical twins both having autism versus a non-identical twin having autism when their other twin does. And then the risk of autism increases with parental age in general. So it's no longer just thought that it's advanced maternal age. We know advanced paternal age is also a risk factor. And then common comorbidities that we see. So increased risk for epilepsy or seizures, a lot of sleep difficulties and disturbances, psychiatric diagnoses, ADHD, depression, anxiety, bipolar is much higher. GI disorders are much higher. And then really high prevalence of general eating challenges and obesity. And a lot of that's due to diet, which can go back to sensory difficulties. So, and then briefly on assessment, but we could table this if anyone wants to talk more about that. And then getting a good evaluation for autism is really important because there's such a significant overlap, and I'll have this just sent out to you guys to look at, but kind of like I alluded to earlier with ADHD, a lot of things can look like autism, but they may not be autism. And the treatment for autism is a lot different than treatment for other diagnoses. So it's really important that we have a really clear picture of what's going on for the person. Okay, hopefully that was within my time frame, and I am happy to answer any questions.
Thank you so much, Claire. Great job. And that was really interesting. I know it felt like you were fine, but you did really good.
Okay. I wanted to make sure I was like within my time frame. I know it was short.
If you went a little over it, I promise it's okay. But does anybody have any questions, or, you know, if we want to discuss this even further or narrow it down, please, you know, email or just let us know. We can discuss it further too.
Autism's a tricky one. I mean, I think Dr. Wallace and I did a 3-hour presentation for staff at Raynell Medical Center a couple months ago, and we still didn't feel like we had enough time to cover everything. So always happy to consult too, as needed.
Yeah, I'm gonna steal the opportunity to invite you back and ask this group, maybe because they may not know some of your special talents on specific treatment issues with regards to autism, but I will share your vast knowledge. I kind of think it'd be really nice as future topics to kind of talk about maybe adapting treatment for trauma, or adapting treatment for anxiety, or adapting treatment for some of the sexual behaviors that sometimes we see in autism, just very specific things, because I know that a lot of times our kids with autism are being seen in the community by experts in their field, but not always feeling like they're experts in autism or how to adapt sort of the general psychiatric treatment needs for the autism. And I kind of wondered if that is something you'd be willing to come back and share, and then kind of ask this group what areas specifically they might want to see. I personally would vote for the adapting like trauma treatment for autism, especially to help kind of build that how kids might view trauma differently with that lens sometimes of not always understanding other people's perspective. I think can be an important part to adapt. And
Absolutely.
So
and somebody else that could speak to
see what you thought about that.
Yeah, I would love to speak more on, just give me a topic and give me a little bit of notice so I can pull something together. But I will say Dr. Maria Khan, one of the new child psychologists over at CRC, her specialty is childhood trauma, and she has a subspecialty within that of neurodevelopment. So she might be able to speak more to that than I can in terms of the trauma lens. But in the other areas,
they just released something she did on IDDD trauma adaptation. So that might be a good.
She might be she's going to be better up to date with that, and trauma is more of her focus. So I think that she would be the better person to talk about that specifically. But the other areas, I'd be more than happy to talk about. If you guys just wanted to send out a list or something at some point, just let me know.
I know you have done a lot with the sexualized behaviors, and I'm sure that's a topic this group wants to hear more about too. I just
yes, absolutely.
I know Pauline does. She's sitting there smiling. I didn't know if there were other folks. I know a lot of people on PBS are seeing some needs too. So are there any needs that the PBS team kind of would want adapted for treating in autism?
Yeah, see thumbs up from Anastasia. Go ahead.
Oh yeah, I think that the sexually reactive acting out, I think is really helpful. Like on some intervention ideas and how to help with that. That'd be great.
Yeah, absolutely.
Writing those down, absolutely. And we're just now like working on the curriculum for the first half of next year. So I'll reach out, Claire, with the remaining dates and see a day you can present, and probably reach out to Dr. Khan as well again, just for some guest honors. Lauren, you're on mute.
Dr. Khan did OCD a couple of weeks ago, and a really cool thing that kind of came out, they were talking about differentiating kind of the repetitive behaviors from OCD and autism, and just how treatment strategies would maybe be different. And so I think like how do you address and break sort of the repetitive patterns clinically and with treatment with autism could be quite different than just traditional OCD. That might be another important topic. That was one lots of people had questions about too.
Absolutely. It can get tricky even just trying to tease apart diagnostically. But I think that it's really good to kind of understand that those treatment paths look a lot different, because you want to make sure that I think OCD and autism in their both respects need very specific types of treatment, and they're not similar. So that's a good area.
Had a comment, saying it would be helpful to get more information on how to meet people with autism at their communication levels, figuring that out, helping families to understand that unique communication need. Absolutely.
Right. Yeah, absolutely. And I would love to be able to speak on that. I mean, I can answer it in a couple minutes. I could, but I can briefly, I think just knowing what the person's communication level is, first of all, and understanding that receptive language is different from expressive language. So receptive is what we understand and expressive is what we get out. And commonly, when you hear someone talk or struggle to speak, you assume that they understand at the same level. And that's not true, because those are two different pathways in the brain. So one can be more effective than the other, or both can be equally affected. So that is certainly something that we have to really understand, and potentially evaluate for it to see kind of what is the receptive language or the level of understanding versus the ability to get out information in a way that is understandable to other people. So that would be the first thing. And then from there, it's really about figuring out where are they developmentally in their understanding of information. So even if the child is 15, is their receptive language so delayed that we need to speak with them as if they're 5? And that's not because we're trying to be demeaning, but it's because we're trying to meet them where they are. And so that gets, I think, trips up a lot of clinicians too sometimes, because it feels like you're being demeaning and you're not, as long as you are truly meeting them where they are and not just assuming. Or, you know, a lot of visuals are really, really helpful, because we know that in patients with autism, that visual spatial skills are typically a strength in their profile. And so if we can add a visual component, and that is a picture that is demonstrating something, that is even for patients that can read and comprehend, it's writing something down, because that is still them reading it visually. That is going to be easier to understand than having a conversation. So that verbal comprehension component is often more delayed than the visual spatial component. So really leaning into some semblance of a visual to go with things, and maybe limiting what we say and giving more guidance through visual supports can be really helpful.
Thank you so much, Claire.
Of course.
Are communication assessments a regular part of an autism diagnosis, and how frequently are those reassessed?
Great question. I think it kind of depends on where you're getting your autism diagnosis. So thinking about the big clinics at major hospitals, at the NDC, we don't incorporate speech pathology into our evaluations, though we are often referring to speech therapy if they're not already in speech therapy. And there's some things that we can do as psychologists to try to evaluate for that, but that's not our specialty. so really what we're looking at is in other locations is they have maybe more integrated teams, and that just depends on how the model is for that center. There's no right or wrong way to evaluate for autism in that regard, but some will have, speech pathology and occupational therapy and psychology all in together. And each person does their respective testing and kind of comes together to look at things, but there's not a kind of standard communication component that we're doing to evaluate for communication level. It does now, level of communication does impact the type of testing that they're going to get for autism based off the ADOS. It's got different modules that you give based on language level, which that's a whole other conversation, but we are not actively assessing for that. Speech therapy will do evaluations, and they have to do them every so often for insurance reapproval. So that would be the place to kind of get those. And often that's I would say on average, I see about every 12 sessions they need to apply for reauthorization. And so they have to have data to support that. So speech is who I would refer to for that. Unfortunately, speech therapy is one of the most needed, second to ABA, treatment for autism. So they do have extensive wait lists, but most insurances cover speech therapy, unlike ABA. So, and there's more speech therapists than there are BCBAs and RBTs. So it kind of weighs out that way, but it's still going to be a several month wait, most likely, to get into speech.
Yeah, I have a question about that, Claire.
Yeah.
I don't know how best to look for that. I've had some, especially when you're like talking about assessing pragmatic speech, there seems to be like, they can get kind of more in the weeds with phonological issues and speech production, but the treatment for the pragmatic and assessment even for pragmatic speech is a little bit of a different beast. And I'm not sure I have determined the best way to ask about that when I make speech therapy referrals. Do you have any advice on that, or are all speech therapists?
So every speech therapist should be able to do pragmatics. So for people that don't know, pragmatic language is like your social language. So you can speak. It's how do we use that communication in maybe a conversational manner or to get along socially and navigate our world in that way. Every speech therapist should be able to do that. Some just don't prefer it. I mean, everybody gets kind of trained broadly in their field and then kind of narrows in their interests. But I haven't had an issue when I've worked with providers that have referred for speech for pragmatic language. Now, justifying that for insurance may be hard. But I think that
I think I've seen the
I haven't
challenge
had any issues.
I think I've seen the challenge more in schools, because a lot of kids are getting therapy in schools and they don't.
So schools are gonna probably tell you no, because they're able. So the whole point of school-based services, which could be a whole other talk if you'd want, the whole point of school-based services is to get a child through the school day. So if you can talk and you can comprehend and you can have some semblance of a conversation, the chances of you getting speech therapy for pragmatic language is poor. I think that in West Virginia, the cutoff is like an 80%. You have to be like 80% proficient and you're fine. Which of course, a lot of people want their child 100% proficient. So that's not necessarily helpful, but we also have to think about all of the children that really need those services receptively, expressively, whatever it might be. The numbers for students and their needs far outweighs the number of providers that are in the schools. So especially in rural areas or rural parts of the state, we see maybe there's one speech therapist for the entire county. So every kid across the entire county that needs speech therapy, this provider has to provide services for. So then you get things like, seeing so many times a month versus seeing weekly, or being put in small groups instead of one-on-one, because they have to legally, by federal law, accommodate this, but it's one person with however many students on their caseload and 40 hours in a week. So that gets really, really challenging. So oftentimes when students are not able to get the pragmatic language support through schools, then I will encourage families, if they're able to, if it's within driving distance, a reasonable driving distance for them, to seek out outpatient, or to do both if they get both, because that is always great to double that way. The other thing too with schools, just for people to know, is that you'll get schools that will say like, oh, give us your insurance so we can bill for your services, but any service provided at the school is free. So when they bill that insurance, it takes out of the number of sessions that they can get outpatient. So if they're doing outpatient too, and like Blue Cross Blue Shield only gives 20 sessions a year before you have to pay in full out of pocket, then if your school is using those 20 sessions, but you want outpatient, then that's not fair when the school can provide it for free. So you can always revoke that or encourage your families not to give over that information, and it won't hinder any services. And Teresa, yes, I think seeking out speech language assessments is appropriate. They are going to need an order from a physician or medical provider just for insurance purposes, but absolutely, I think referring for speech therapy evals is very appropriate.